Hello and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Rahul Banerjee from Fred Hutchinson Cancer Center, lead author on Treatment of Multiple Myeloma, ASCO Living Guideline version 2026.1.1. Thank you for being here today, Dr. Banerjee.
Thank you for having me, Brittany.
Before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Banerjee, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to dive into the content that we're actually here today to talk about, Dr. Banerjee, this living clinical practice guideline for treatment of multiple myeloma is updated on an ongoing basis. What evidence prompted this latest update, and how did that impact the guideline recommendations?
I think living guidelines are an excellent idea, and I think all guidelines should be updated every couple of years. If you look at the timeline of this one, you'll see it was updated basically 6 months after the last set. And you may say, what on earth was such a big deal that you had to update these guidelines? True that you had to. And it really was the Majestic-3 trial. So this was a study of a bispecific antibody or a bispecific T-cell engager in multiple myeloma called teclistamab, plus a CD38 monoclonal antibody called daratumumab in patients with 1 to 3 prior lines of treatment. Bispecific antibodies are T-cell therapies. Many of you listening to this are quite familiar with T-cell immunotherapies in many ways or forms. These aren't checkpoint inhibitors. Checkpoint inhibitors that many ASCO members are well familiar with in solid oncology, like pembrolizumab and nivolumab, they unleash your endogenous T-cells that already know how to attack the cancer to do it better and not be shut off. Here, in many blood cancers, the T cells will never learn to fight their own. In a cancer of the immune system, the T cells walk past their cancerous brothers and sisters, so to speak, right? There's no way for them to target the myeloma cells. With a bispecific antibody like teclistamab, you basically blindfold the T cell, redirect the T cell. You take the protein called CD3 that it uses to see the world, you block it and say, hey, stop attacking whatever you're supposed to be doing and go attack this thing instead. The bispecific antibody has 2 arms. One blindfolds the T cell and one grabs the myeloma cell in this case and puts them together. In this trial, they randomized patients at first relapse or later with multiple myeloma. Remember, myeloma, inevitably with traditional treatments, patients, if they live long enough, will have a relapse of the disease in the traditional paradigm. And they randomized them to either get traditional treatments, including a therapy called daratumumab, daratumumab, pomalidomide, dexamethasone, that I have used all the time myself for my own patients here in Seattle, versus teclistamab plus daratumumab. Teclistamab being the bispecific antibody, daratumumab being this commonly used monoclonal antibody. They included patients who had received daratumumab before, but not patients who were refractory to daratumumab. The data were sensational. The hazard ratio for PFS was 0.17, meaning an 83% lower risk of disease progression or death during the study period that we have so far. Similarly, 3-year PFS was 83%, meaning that of these patients with relapsed myeloma at the 3-year mark in the group that got Tec-Dara, the bispecific plus daratumumab, over 80% of them were still in remission. And that's sensational. That is way better than any treatment in the relapse setting that we traditionally use outside of CAR T therapy. In all honesty, that's better than some of our traditional therapies in the frontline setting. And these are patients with relapsed myeloma. So I think that was really cool. Got a standing ovation at the ASH meeting last December when it was presented and published in the Journal of Medicine. And then it was approved in March thereafter. One of the fastest turnaround times I've ever seen in my life, where the data first became available to the world in December, and almost immediately the FDA was interested. And within 3 months, an FDA approval, and I've already started using this combination off trial for my patients. These data were basically so sensational and the approval so rapid that we felt compelled to update our guidelines accordingly. And in brief, now at first relapse, we had traditionally said, look, go for CAR T therapy, or go for a traditional triplet. Traditional triplet meaning conventional regimens, so some of you may be familiar with. I won't go through the full names, but Dara-PD, Dara-KD, Isa-KD, Isa-PD, Elo-PD. Choose your 3-drug cocktail out there. We've now updated it to say, look, CAR T therapy or bispecific antibodies are preferred for these patients, and a triplet should really only be reserved for patients who are not candidates for these immune-based therapies or do not want these immune-based therapies, or obviously if an immune-based therapy was given and stopped working. So I think that's a big shift in our thinking about myeloma, that immune therapies, be it CAR T or bispecifics, are now at the forefront of relapsed myeloma. And that was the biggest part of our updated guidelines.
There's been a lot of movement in the multiple myeloma space. I thank you for reviewing the results of the MajesTEC-3 trial and how this impacted the recommendations for relapsed or refractory multiple myeloma and the preferred options there. There were also additional trials that the panel reviewed during this update period. So what additional evidence did the panel look at that has not led to recommendation changes in this latest version?
There's two parts to that. One is, what parts of MajesTEC-3 did we not put into the guidelines? And number two, are there other trials that we didn't incorporate at this point in time? For the first sub-question, MajesTEC-3, I kind of alluded to this. We enrolled patients on that trial here at Fred Hutch. Right? This was a global study, including United States patients. But only 5% of patients in that study had ever received a drug called daratumumab, a CD38 monoclonal antibody, and no patients were refractory to it. In my practice today, for example, 100% of my patients with multiple myeloma, newly diagnosed in the last 5 years, have been receiving daratumumab. A little bit of a mismatch there in terms of, well, this doesn't quite match current contemporaneous US practices. And so technically, those patients who received daratumumab, we don't yet know how much better they did versus did not do. And so what we tempered our guidelines with is that we said very clearly that for patients who have disease that is refractory to daratumumab, they've been on daratumumab and the drug stopped working, it is not yet recommended. We don't have the data yet to say that we would recommend MajesTEC-3 in that particular cohort. Technically, we don't know because MajesTEC-3 did not enroll Dara refractory patients, but it's not appropriate for us to make that recommendation now. Importantly, at the upcoming ASCO meeting in a couple of weeks, or really next week, we're recording this in late May, MajesTEC-9 will be presented. We have a press release from it. That's the study of teclistamab monotherapy, including in daratumumab refractory patients. So not tec plus dara, just teclistamab by itself. We didn't include that in these guidelines, one, because all we had at the press release, and two, because we need to see the data to really say. Well, that's the one. There were a couple other publications that we looked at that I think are helpful to include, but not enough to quite change management. One, I think that's worth noting, a really nice study, international study within Poland and University of Chicago called the ATLAS trial, looked at two strategies for post-transplant maintenance. As many of you know, autologous stem cell transplantation is still a mainstay of management for newly diagnosed myeloma. It's consolidation. Once you get them into remission with induction, you talk about doing a transplant for patients under the age of 75 in the US. After transplant, you still have to put them on something because transplant is not considered curative. Traditionally, we often use just one drug with lenalidomide, maybe two, lenalidomide plus something. This study looked at KRD with carfilzomib, an intravenous proteasome inhibitor, plus lenalidomide plus dex versus lenalidomide alone. KRD did much better than lenalidomide. The reason that we don't routinely recommend this to patients is just it's a lot. Maintenance is when patients are in remission. They have often just gone through transplant. This is a chance to rebuild their lives. And carfilzomib is often given once a week IV or at most once every 2 weeks IV. That means 2 to 4 times a month coming in for treatment while in remission is a lot. For some patients, it is warranted for patients with high-risk disease in some way or form. And I do discuss it with patients, and I have patients on this style of maintenance, but it is not the routine. It's interesting that we don't recommend that for everybody, even though the trial was positive, but just for that reason. I think that because every patient's values are different, and with these new bispecifics and CAR T being available at relapse, you could argue that maybe you don't need to overtreat people during maintenance. So that trial did not make it into our guidelines, but I think it's worth a read.
Thank you for helping put those recommendations into context and what made it into the guideline, what hasn't made it into the guideline at this point, and where we'll await some future trials. In your view, what should clinicians know as they implement this updated recommendation, and how do these changes impact patients with multiple myeloma?
CAR T therapy and bispecific antibodies like Tec-Dara are on equal footing now in relapse disease, which is wild. That is a very big change from a year ago, where bispecifics were only approved for much, much, much later lines of treatment. And we always recommended CAR T before bispecifics. And compared to 4 years ago, right, where there really were no CAR T or bispecifics approved in early relapse, right? They were only approved for late lines of treatment. And so when the question comes, people often ask me, right, well, how do you choose? How do you do? If a patient were to ask you, should I get CAR T or should I get bispecifics? The answer should be yes. You should get one of them. So the decision between CAR T and bispecifics is extremely individualized. And I encourage clinicians who have access to one, but not both modalities to refer their patient to the other center to get a balanced perspective. Even if your center does not offer CAR T, it's worth discussing with a CAR T center, having the patient meet with them and hear about their options. Because in brief, I could talk about this for hours, but CAR T therapy like cilta-cel, ciltacabtagene autoleucel, or ide-cel, idacabtagene peglosil are the two generic names that are FDA approved currently. They have a lot of work going into them, but it's a one-time infusion, a living drug, possibly curative in myeloma based on what we've seen from cilta-cel, which is really cool, but not for everybody because a lot of logistics that go into it. Some people, those logistics of relocating to a CAR T center are not possible. Some patients are just too frail or have too many organ issues, making CAR T not safe. Some patients don't have a caregiver. Some patients are apprehensive about CAR T's side effects in terms of delayed side effects like Parkinsonism has happened in a rare amount of patients, et cetera, et cetera. For those patients, a bispecific based regimen like teclistamab is entirely appropriate. And so that's, I think, what I would encourage clinicians to remember, that the default really should be CAR T or bispecifics. In my head, I have often thought about these immunotherapies historically as being kind of last line because that's how they were first approved, that 4 prior relapses. And you're like, oh, how do I get them with traditional treatments to get them to 4 prior lines to get them to CAR T? That paradigm has changed. 5-10 years from now, probably CAR T and bispecifics will be the first in frontline management. We're not there yet, but my point is the future is coming. And these therapies, whichever one you choose, it should be one of them for the vast majority of patients. On the other hand, the real loser of these debates, in a good way, is the traditional triplet. We updated the guidelines accordingly. Dara-PD, Dara-KD, ISA-PD, ISA-KD, ELO-RD, ELO-PV, PVD. I could go on and on and on. We used to just recycle newer versions of these older, same 3, 4, 5 classes of drugs. Some patients may still need them. Some patients may still start them as a bridging therapy to get to CAR T therapy, just as an example. Some patients may not want CAR T or bispecifics, or may not be a candidate for either. But I think it's worth noting that those triplets are rapidly going to become the minority of patients and not the majority of patients. Many of us, our default when someone has a relapse, at their first relapse, we think about a CD38-based triplet. That thinking should really be replaced with, let me think about CAR T therapy or a bispecific antibody.
Absolutely. And that individualized shared decision making that you talked about is really paramount for making these decisions for patients.
Absolutely.
And for them to consider all of those factors that you mentioned in what is the best option for them between those 2 preferred options before moving to triplet therapy as well.
Exactly right.
So then finally, the panel is now reviewing evidence on our 8-week living guideline cycle. And you've already mentioned the Majestic 9 trial that will be presented at the ASCO 2026 meeting. But what other evidence is on the horizon for future updates to this living guideline?
I'm on the committee, obviously, and we're working on the next set now. And it's already, we're kind of like, oh, when do we stop looking for papers? You got to, at some point, stop looking for papers and write the new set of guidelines, but the field is going to continue to shift. So Majestic 9 is looking at teclistamab by itself, basically, in this setting. Monumental 3 will be published, will be an oral plenary at the EHA meeting in Stockholm later in June, a couple of weeks after ASCO, showing that talquetamab plus dara plus pomalidomide, talquetamab plus daratumumab also works well in this setting. Talquetamab is a different bispecific antibody targeting a different protein called GPRC5D. It's not BCMA. The idea is that all of our currently available CAR T therapies target BCMA, and most of our bispecific agents also target BCMA. And so you kind of have to choose between them. I'm okay with whatever my patients choose, but in reality, you can't mix and match between them as easily because both target the exact same protein. And if you go straight from one to the other, it often doesn't work as well. And so this will also break that paradigm because then if that leads to an approval, depending on how the data look and what happens in the US, Canada, Europe, et cetera, then you'll have a non-BCMA option as a bispecific at first relapse available for patients who want the benefits of a bispecific antibody, but don't want to target BCMA. They're still interested in BCMA CAR T later and want something different now, and that's very reasonable. There's a lot of work we have yet to do to learn to optimize bispecific antibodies in terms of spacing out the dosing, time-limited therapies to limit T-cell exhaustion before subsequent CAR T. Talquetamab has its own side effects that we can talk about some other day, skin, nail, and tongue issues that can be really burdensome for patients, we have to discuss. So that's going to be one big bucket. The other big bucket in the next 6 months will be a lot of our data around CELMoDs. CELMoDs are a new class of therapy being studied in myeloma and lymphoma primarily that basically compared to lenalidomide and pomalidomide, they target similar proteins, but in a almost comically better manner, to the point where lenalidomide and pomalidomide are so lousy compared to these newer drugs and compared to blocking the traditional substrates, something called Icarus and Aiolos that these proteins do. And also, these new drugs also activate T cells. Half of what I've discussed so far involves T cells, CAR T this, bispecific that, etc. And so the two CELMoDs, iberdomide and mezigdomide, that are in late stage investigations, promise to really change the field when they're here. One, because they work better than traditional lenalidomide across the board. And even in case of when lenalidomide or pomalidomide stop working, the new drugs will work. And two, they work to reduce T cell dysfunction, to reduce T cell exhaustion. And so in this paradigm where myeloma was moving towards all immunotherapy-based regimens like CAR T and bispecifics, having these CELMoDs available as synergistic agents or as agents for maintenance thereafter, I think will be really cool. In particular, we know from a press release that iberdomide in the Excalibur RRMM study met its primary endpoint in relapsed myeloma, and that should possibly be approved by the FDA this summer or fall. Similarly, at the upcoming ASCO 2026 meeting, Successor 2 will be presented, and those are data with mezigdomide plus carfilzomib plus dexamethasone, mezigdomide being another CELMoD. And so I don't have the full results of these trials yet, obviously. I'm very much looking forward to seeing them at the ASCO meeting and seeing what the FDA says about them in due time. But that will be the other big change in the coming months. May not be in time for the next iteration of the living guideline, but the one after it, absolutely. Because I suspect at least one of these CELMoDs will lead to an FDA approval if the data are as good as we've heard they'll be.
We'll look forward to the presented and published results of these important trials, and as more important research questions are investigated and really change the treatment paradigm for multiple myeloma. I want to thank you so much for your work to rapidly update this living guideline. And thank you for your time today, Dr. Banerjee.
Thank you, Brittany. I appreciate being here. It's a lot of work, but a lot of fun. And I'm glad people are listening and reading the guidelines.
Definitely a lot of work. And so we appreciate every little bit of it that you do. And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/hematologic-malignancies-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.